Hello and welcome everyone. On behalf of the Northwest Mental Health Technology Center, welcome to today's webinar, Common Ground, Mental Health and Addiction Peers. We're grateful you were able to join us today to learn more about this important topic, and we look forward to sharing and exchanging information with all of you. My name is Adrienne Scavera, and I'm the Training and Outreach Director for Mental Health and Addiction Association of Oregon, one of Oregon's oldest and largest peer-run organizations. I'm presenting today with my colleague, Janie Gullickson, our Executive Director. Next slide, please. The Mental Health Technology Transfer Center Network is a nationwide network that's supported by the Substance Abuse and Mental Health Services Administration, or SAMHSA, with the purpose of disseminating and implementing evidence-based practices for mental health disorders into the behavioral health workforce. Next slide. The Northwest MHTTC is based at the University of Washington in the Department of Psychiatry and Behavioral Sciences. The Northwest MHTTC provides training and technical assistance, or TA, in evidence-based practices to Region 10. That includes Alaska, Idaho, Oregon, and Washington. Next slide. There are a lot of great resources available on the Northwest MHTTC website, available at www.mhttcnetwork.org/Northwest, including free upcoming events, online courses, products, and research briefs. Next slide, please. We couldn't do this without the support of SAMHSA, and of course, this content is not reflective of any SAMHSA official positions. And I next want to share a little bit about language on our next slide. It's our intention to always be mindful of using language that promotes recovery and culturally appropriate terminology. We encourage everyone to use and champion person-first language, language that is inclusive, non-judgmental, respectful, clear, and understandable. And with that, I have a couple of logistical things to share on our next slides. The first is about our chat box. That's where you can share any technical issues, non-content questions, as these chat box comments will only be visible to us and the Northwest MHTTC staff who are assisting. The staff may share things that come up that aren't strictly content related through the chat as well. Our second option is available on our next slide, which is questions. So we really value the questions that we have in your engagement today. Everyone is automatically muted in this webinar, and there is the option today to type your question into the Q&A window. We've got an image here showing the Q&A window. Just a reminder, that is different than the chat box. The Q&A window is where you will put all your relevant content-related questions, and you can actually see the questions that others are asking and upvote those as well if folks are asking questions that you also would like to see us respond to. If we don't have time to get to all of your questions today, we will be sure to follow up and get a response to you afterward. So please know that if you've asked a question and we don't have time to address it during this live webinar. All right, and I have one more logistical piece of information to share, which is about our evaluation survey. Feedback is really, really important to the Northwest MHTTC and to us, and we have a short survey that we'll share in the end through the chat box and through an email as well. The survey responses are anonymous and they help us plan future sessions. I did want to let everyone know that we are not able to provide certificates or CEUs for this series, but the slides and resources will be available on the Northwest MHTTC website after this session. All right, now that we've covered all of that logistical information, I would like to spend a little bit more time introducing myself and my fantastic colleague, Janie. So as the Training and Outreach Director for Mental Health and Addiction Association of Oregon, I work to support the peer workforce from initial entry and training and certification to systems level advocacy while using both my lived and my professional experiences. Janie, Executive Director of MHAO, is a person in long-term recovery and has lived experience navigating multiple systems. Professionally, Janie holds an MPA-HA in addition to peer support certifications. And with that, we're going to get right into our webinar. And the very first thing I want to do is launch a poll because I'm interested in hearing who has joined us today. So you should see a poll that asks which of the following best describes your role: peer support specialist, peer recovery specialist, clinician, peer supervisor, administrator, social worker, or other. So please take a moment to respond to this poll so we can see who is joining us today. Great, I'm seeing a lot of responses come in. I see we've got about a third of the group are peer support specialists, about a third are social workers, and about 15% are peer recovery specialists. Okay, so I'm going to leave this up for about 5 more seconds and then I will close this poll. All right. So I'm sharing the results here so everyone can see who is with us today. We have a third of our group identifies as social workers, followed by peer support specialists, peer recovery specialists, and other. All right, and with that, thank you all for filling that out. That's always good information to know to see who is joining us today. So we're here today for the Common Ground webinar. We're going to be looking briefly at the history and practice of mental health and addiction peers, focusing on the commonalities that bring us together. And with that, we have a brief acknowledgement we'd like to make on our next slide. This presentation is adapted from a 2018 presentation at the Peerpocalypse Peer Leadership Conference, Common Ground with Eric Martin and Janie Gullickson, who is here presenting today with permission from the authors, of course.
Thank you, Adrienne.
Thanks, Janie, and thanks so much for being here. Today, we're going to be doing a brief and broad overview of the common ground between mental health and addiction peers, looking both at the history and practice. We're going to have a lot of interactive polling throughout this webinar so that you're going to have a chance to share your thoughts and your ideas. At the end, we'll have some time for the question and answer period. So as Janie and I are talking, if questions are coming up for you, please do use that Q&A box option because we will come back to the Q&A box at the end of the presentation and respond to the questions that you all have entered there. And our next slide, and then the next, please. So if you've done a webinar with us in the past, you have seen this image and this quote because it really is one that is very striking. This was in the late 1700s where Jean-Baptiste Poussine, who was a former patient of a Parisian hospital, who later came back to that hospital and became an administrator, the superintendent of the hospital, recognized the value of lived experience in providing services and supports. This quote here is from Jean-Baptiste to Philippe Pinel, who is considered the founder of the moral treatment movement. Next slide, please. Within his time at the Parisian hospital, Jean-Baptiste banned the use of chains and other inhumane restraints, which were commonly utilized at that time. We began to see a transition of services to moral treatment, which supported the treatment of people receiving services in healthy environments and in an appropriate and humane manner, something that was a drastic difference from how service delivery had previously looked in hospitals and for folks who are receiving services around their mental health experiences. And on our next slide, we've got a poll that I'm going to be launching. And I'm going to read this out here, and the poll is also live. In modern terms, the moral treatment movement of the late 1700s sounds a lot like, do you think it sounds a lot like cognitive behavioral therapy? Like person-centered care? moral recognition therapy, spiritual treatment. I'm seeing some responses come in. Excellent, thank you. I'm not going to reveal the responses just yet because I want folks to have a minute to share their thoughts with us here. So we're going to leave this open for about another 15 seconds, and then I'll be closing this. Fantastic. I see a lot of people responding. All right. I am going to close that poll. So you've got a tiny bit more time if you're thinking about which of those responses you want to put in here. Okay. So I am now sharing the results with everyone. So it looks like a majority of our group here today, 56%, say in modern terms, the moral treatment movement of the late 1700s sounds a lot like person-centered care. That is correct. There were also some other ideas about it sounding like moral recognition therapy, cognitive behavioral therapy, and spiritual treatment. But you're absolutely correct. The moral treatment movement of so many years ago has some similarities with person-centered care that we currently see in practice today. And Janie is going to take us into our next slide.
Thank you so much, Adrian, for giving us that background and sort of first record of that early days of people with lived experience offering support and advocacy for those going through, hospitalization and the beginnings of those moral therapy and moral treatment movement. It was in the tradition of wounded healers as well, the belief that recovery from devastating illnesses was a sign of a healer, where Native American sobriety circles led by tribal members who'd survived their own battles with alcohol, became leaders and used their own recovery to launch abstinence-based movements that called for the complete rejection of alcohol and a return to their ancestral traditions and cultures. And so looking back to the beginning of the moral therapy movement in the 1700s, that was in France with John Baptiste and Dr. Pinel, but in the United States, the first proponent of moral treatment was Dr. Benjamin Rush. He was a Philadelphia physician, and besides being one of the signers of the Declaration of Independence, Dr. Rush believed it was the hustle and bustle of modern life that contributed to mental health issues that he called mental diseases. Sort of sounds familiar with, current times, that it is a reflection of, the stressors on society and that sort of accomplishment mentality that can add to stress and cause mental health challenges. Such diseases, he thought, could best be treated in a hospital setting away from those stressors of modern life. But also would like to note, not everything Dr. Rush used as a treatment seemed in alignment with that moral therapy movement. He used things, strategies like bloodletting for some conditions. He invented the tranquilizer chair as a restraint for people who he deemed agitated. But he also advocated for sober houses that, seem very close to the Oxford houses or sober living homes that we see today, staffed with reformed drunkards. So, other people in recovery supporting those on their recovery journeys. Next slide, please. We have common ground. Addiction and mental health peers are person-centered. So much like you in the poll mentioned that the moral treatment or moral therapy was connected or seemed like person-centered care, people sharing their lived experience and walking shoulder to shoulder, supporting others going through a similar life experience is also very person-centered, also known as person-directed, or having that person being served, or even the patient being the driver of their care. Next slide, please. Addiction and mental health peers help others through their lived experience. Another area of common ground. Next slide, please. A little more about Benjamin Rush. His father was an alcoholic. He was a doctor early on who said that alcoholism was a disease and not a moral failing. But he also writes, applying society's resources to the efforts of science and humanity in treating a disease induced by vice will meet with a cold reception. Next slide, please.
And thank you, Janie. With that, we want to hear everyone's take on that quote that Janie just read. So I am going to launch our next poll, which is all about Dr. Rush's quote and what that means. Applying society's resources to the efforts of science and humanity in treating a disease induced by vice will be met with a cold reception. What does that mean to you? A, people don't want to pay for addiction services. B, science always fails humanity. C, people don't like science. D, addiction is a disease. Excellent. I see people are coming in with some votes here. Thank you so much. We're going to leave this open for about another 15 seconds. I'm going to close the poll in just another couple of seconds, so please get that vote in if you haven't already. All right. So 63% of us today said people don't want to pay for addiction services. That's what that quote from Dr. Benjamin Rush means. Applying society's resources to the efforts of science and humanity in treating a disease induced by vice will meet with a cold reception. People don't want to pay for addiction services. And then we had some folks say that addiction is a disease as well. Excellent. Thank you all for participating in that poll with us. If we could get perfect. And another common ground. So you're gonna get familiar with these because it's where you see those big blue letters and that image. That's where our common grounds are. Society doesn't give sufficient resources to fund addiction and mental health services, both these services alike. The National Council for Behavioral Health released a new initiative, Unite for Behavioral Health, that is seeking to address this very challenge of society underfunding and undervaluing mental health and substance use care. And this has resulted in some pretty unacceptable results. Today, the National Council for Behavioral Health states that only 43% of all people living with mental health challenges receive treatment or services. And only 12% of Americans who experience a substance use disorder receive specialty treatment in any given year. So these numbers are very small and could certainly be improved with additional resources and increased access to care and services. Janie's going to share a little bit about the Washingtonians on our next slide.
Thank you, Adrienne. It still just stuns me that almost 2 centuries later, we still are struggling to fund, a whole continuum of care, including peer services, even currently. So thank you for those statistics and pointing that out. A little bit about the Washingtonians. They were the first nationwide large-scale alcoholism recovery movement. The Washingtonian Temperance Society started in May of 1840. It was 6 Baltimore drinking buddies who decided to write and sign a pledge stating they would no longer drink alcohol. This 6-person pledge turned into one of the largest movements in America. They would lecture around the country, showing people sharing their experience, real life stories about what it was like for them when they were what they called abusing alcohol. And by the end of 1841, Washingtonians claimed that over 200,000 people had signed their pledge. And then by 1842, they said they had recruited over 1 million people. This organized effort lured and got the attention of women. And so in 1842, devotees of the Washingtonian Temperance Society created the Ladies Chelsea Temperance Benevolent Society. So that was, not for men only. Next slide, please. Where's that? Common Ground. Oh, no, sorry, I apologize. I went ahead. So the Washingtonians' initial political advocacy, focused on alcoholism and the inhumane treatment of those with mental health issues and alcoholism. So that was another early blending of the movement. And then next slide, please. Thank you. Over 100 years later, the consumer survivor ex-patient movement becomes vocal and organized. That special insight from actually having had lived experience themselves of being a patient, a consumer of psychiatric services, was the grounds that the ex-patient, psychiatric survivor, and consumers began to assert their right to speak on their own behalf and become empowered and know their rights. An early survivor of this movement and participant in the movement, stated that it followed in the footsteps of important civil rights movements and recalled its leaders dressed like hippies and talked like militants. The accounting of the history of the movement gives recognition somewhere here close to home in Portland to the Oregon Insane Liberation Front, founded in the late 1969 and early 1970s. It was known as the first consumer-run rights group. Other groups soon followed, though, in New York, Boston, San Francisco, and there was the founding of the 1972 newsletter, Madness Network News, and that sense of a broader movement with common goals also began to develop. Next slide, please. Here we are at Common Ground. Addiction and mental health peers fight against the criminalization of health disorders. And next slide, please. We also look to Alcoholics Anonymous, and the main reason we mention AA so frequently today is that it is the largest or one of the largest self-supporting peer recovery movements in history. And we believe in many paths in self-directed recovery, and we honor an individual's right to choose their self-directed path, but peer support and that concept of one person experiencing something similar to another can offer that unique support and understanding and build that connection from that shared lived experience. Next slide, please. And we see this in that iconic image of the man on the bed. So it shows the founders of AA here, Dr. Bob and Bill, and they were quoted as saying to each other, if you and I are going to stay sober, we'd better get busy. And so they called the hospital in Akron City Hospital, and told a nurse that they had found that cure for alcoholism. She asked, on whom had they tried it out? And, they said they had already tried it themselves and wanted to share this newfound cure. And so she told him of a man who had just come in to the hospital. He had blackened the eyes of 2 nurses and was now strapped down tight. And she's also quoted as saying he's a grand chap when he's sober. And that was Bill Dotson. And at the time of his death, because of that support of the growing AA group and fellowship, Dr. Bob and Bill, he had 19 years sober. So pretty amazing. Next slide, please. Thank you. And we also see Bill W. here quoted as saying, even though they had felt they found the cure for alcoholism, they also acknowledged that a recovery journey is unique to the individual and that there are many roads to recovery. Next slide, please. And we also see that AA started out with membership regulations, limited to those termed pure alcoholics. There were a lot of exclusions. They had a whole list. I don't have that at top of mind, but it included quite a few different people. But then they determined that really the only criteria should be a desire to stop drinking. And then they became more inclusive. Next slide, please. Here we have another common ground. Addiction and mental health peers have always been on the vanguard of inclusivity. Next slide, please. Common ground. Addiction and mental health peers are diverse and inclusive. So the addiction and mental health peer workforces began as diverse and inclusive, made of folks from all walks of life. We've honored lived experiences and diverse backgrounds. This inclusivity is seen not just in the workforce, but in the many options for support and recovery services. From the time of AA onward, a wide variety of self-help and support groups have launched, including groups such as Narcotics Anonymous, cancer survivor groups, grief groups, and Hearing Voices support groups. And these types of groups and fellowships are found all over the world today. Next slide, please.
And with that, thank you, Janie. We have another poll, which I will be launching right now. So we should start to see questions come up. Narcotics Anonymous, or NA, has now eclipsed AA, or Alcoholics Anonymous, and become America's largest recovery fellowship. Do you believe that is true, or do you believe that is B, false? We'll leave this up for about 15 more seconds while folks weigh in here. Let me tell you, it's kind of riveting from my end because I can see the poll responses as they come in. So it's sort of like a race with the, which one is in the lead? Oh, the other one's in the lead. All right, with that, I am going to close the poll and share the results. Interestingly, we are exactly split. 50% of the group, half the group says, yes, that's true. NA is now our largest recovery fellowship in the United States. Half the group says false. That is not the largest fellowship in the United States. Well, of course, we're gonna tell you what's true here on our next slide. So here we have a breakdown of the top 10 recovery groups in the United States. related to addictions. And then we also have some information about mental health, consumer, and peer programs. As you can see here, with 52,000 groups in the US, Alcoholics Anonymous, or AA, Narcotics Anonymous has a significant number of groups, yes, but still fewer than the Alcoholics Anonymous AA. There are a number of other groups that we also see represented here that have thousands of groups. And then want to briefly highlight for mental health mutual support groups, peer self-help organizations, and consumer operated services. Across those three types, we have a bit over 7,000 of those mental health consumer peer groups in the US. And our next slide, please. Common ground. Addiction and mental health peers embrace many roads to recovery, like that quote Janie had shared just a couple minutes ago. We support individuals on their self-directed roads to recovery and wellness. And we recognize that a different road may have worked for us and that all pathways are valid. And so we really support folks to make those choices for themselves. Next slide, please. Addiction and mental health peers both began advocacy against abuse and for choice. We have two photos on this slide. The first is of Antonio Egas Moniz, who is a Portuguese neurologist who received a Nobel Prize in 1949. The very first person from Portugal to receive the Nobel Prize for his discovery of the therapeutic value of leucotomy in certain psychoses. A leucotomy is a lobotomy. And that inspired American surgeons Freeman and Watts to go on to perform prefrontal lobotomies with the thought that that would be a treatment for folks who experience mental health challenges, but in fact resulted in many more challenges for those individuals who had part of their brains modified through the surgical procedures. Invasive treatments were provided to cure what were considered ailments, mental health challenges, alcoholism, people who didn't identify as heterosexual. All of these things had very invasive and really harmful treatments that were provided. And on our next slide, we have a little bit more information here, which was really in the 1960s was around the time that the anti-psychiatry movement of ex-patients, survivors, people with lived experience vocally started to challenge some of those fundamental claims and practices of mainstream psychiatry. Things like shock treatments or other treatments that at the time were thought to be helpful, but folks with lived experience recognized that they could really have a potential harm against the people on whom they were performed. And as we look at addiction, there was the Lexington Narcotic Farm that was then known as the United States Narcotic Farm, as you can see on this image here. That was a facility that served both as a prison and a place where folks could voluntarily check in for rehab. And the United States Narcotic Farm conducted a number of different experiments on people who were receiving services or who were incarcerated there. And the narcotic farm would provide time off a sentence, or would actually provide payment in the form of drugs to the individuals who volunteered to be a part of the experiments. And new drugs were tested at the United States Narcotic Farm, and then pending the results that it had on the individuals who were receiving services or who were incarcerated there, they would then decide whether it was safe or not safe to release to others. And the United States Narcotic Farm was seen to be very unsuccessful in terms of supporting folks around relapse. Over 90% of the participants who received services there ultimately relapsed. Now, on our next slide, we have a couple of advertisements. These are all real, that really show how medication can be used as a tool of oppression, like we see with these advertisements that market psychiatric medications towards women related to being able to accomplish chores and other responsibilities. So that was very, very sexist advertising, misogynistic advertising of the time. And people living with mental health issues or receiving services were also encouraged to take medications, and peers were advocating for choice. They were saying, we want to be able to choose which medications we take, if any, and have that right to choose to be medicated or not, and really have informed consent within all of that. And we have coming up a poll. I get really excited about these polls. I hope this is something other folks are excited about as well. All right, so our next poll is about tardive dyskinesia. What is it? Is it nervous system damage from prescription drugs? Is it primarily a genetic condition? Is it a side effect from mental health challenges? Is it a disorder caused by female anatomy? Which of those options do you think is true for what tardive dyskinesia is? I see responses coming in. Thanks so much, everybody. All right, we're going to leave this open for another 15 seconds, and then I will close the poll. All right, I'm going to close the poll in just another moment. Thanks so much to everyone who has voted. All right, so a majority of respondents, 80%, said tardive dyskinesia is nervous system damage from prescription drugs. We had a couple of other responses as well, saying 15% saw it as a side effect from mental health challenges, and 5% looking at it as primarily a genetic condition. All right, well, we are about to share what that is on our next slide. So tardive dyskinesia is involuntary, repetitive body movements. It might involve the face, tongue, trunk, upper body, might include our limbs or extremities, that occurs in folks who are treated with some specific types of medications, specifically antipsychotics. So we've got listed here some of the common antipsychotics or neuroleptics that have been known to cause tardive dyskinesia over time. That we also have listed some of the newer atypical antipsychotic agents, which are sometimes linked to this side effect of tardive dyskinesia and sometimes not. And there are also other drugs that may cause this as well, including fluoxetine, which you may know as Prozac, antihistamines, and Reglan as well. And our next slide, please. So we've got another common ground poll as we continue to take a look at side effects that are common ground between both our mental health and addiction peers. Which of the following can cause liver damage? A, alcohol. B, Antabuse, which is an alcoholism treatment drug. C, phenothiazines like Thorazine. D, antidepressants. Or E, all of the above. Whoa, we have a lot of votes very quick, and so far everyone is in agreement. Let's see if that continues to be true as the votes come in here. Wow, people were very quick in voting on this one. I think that's our fastest yet. All right, so I'm going to leave it up just for about 5 more seconds, just in case we've got any remaining votes. Okay. I'm going to share those results very, very quickly. A lot of people went to all of the above, which is correct. All of those items that are listed there can cause liver damage in folks who are taking those. All right, and our next slide, please. So it used to be that courts could mandate antabuse, an alcoholism treatment drug, but they stopped mandating it when they discovered that it caused liver damage in folks who were taking it. And we also saw this for many mental health consumers, survivors, and ex-patients who really felt like they had no say in their medications as well. So it may not have been to the level of being mandated by a court to take something, which sometimes was also true for mental health consumers, survivors, and ex-patients, but really lacking the choice, which in peer work, we always want to offer the ability to choose and respect someone's self-determination. On our next slide, we have another common ground, which is addiction and mental health consumers alike have suffered lobotomies, shock treatment, and forced medication in the name of science. So we just spoke about the side effects, some of the common side effects like tardive dyskinesia or liver damage. We talked a bit about shock treatment or experiments that were conducted related to drugs or medications, lobotomies that could have catastrophic impacts on individuals who had a lobotomy. And at times, there were some folks who received lobotomies, especially when they were younger, who were not told that they had that surgery done in their brain until later in life, and sometimes not at all. So Janie is going to cover our next common ground here.
Thank you, Adrienne. We are at like the peak of the hill of the roller coaster with several common grounds in a row. And we have the common ground of addiction and mental health peers have a healthy skepticism of drug companies. And after all the things that, and that was, just a short snapshot of the things and the types of treatment and drug side effects, forced drugging on both, people with mental health or addiction struggles were subjected to, and all those various treatments or tortures that were considered treatments that people endured. And then if you add on top of that the treatment and experimentation on our Black, Indigenous, and other communities of color, you can just multiply that infinitely as those atrocities were put on those communities, and even more so a skepticism of drug companies, of healthcare providers, those saying they're there to help. We're from the government and we're here to help. So this is something that historically has relevance and has relevance today in current times as well. And I will hand it over to Adrienne.
Thank you, Janie. So we have another common ground, which is that addiction and mental health peers believe in consumer choice and informed consent. And not just believe in, but respect and prioritize consumer choice and informed consent. We believe in transparency and open, honest conversations, and in supporting people to know their rights and responsibilities so they can make informed decisions about what they choose to consent to, if anything. So both mental health and addiction peers strongly value choice. We've got another common ground that Janie's going to share for us.
Common ground. Addiction and mental health peers believe in the rights of the person they're serving, and they are not agents of the system attempting to elicit treatment compliance from consumers or the person they're serving. So as peers, we're not mini probation officers or compliance officers or medication supervising the taking of medication. We're not, there to collude against the person we're serving with the system. And we're there to help advocate for sometimes and support a person in advocating for themselves, to gain information and to practice using their voice if they have never done that before, and support them in sharing what it is they would like to have as a treatment or a therapy or the supports or recovery that they would like to have in their life. Next slide, please.
All right, next we have some information from the Substance Abuse and Mental Health Services Administration and a study that they did that involved over 1 million people over 14 years. They found that 37%, so a little bit more than a third of those with a substance use disorder also experienced a mental health challenge at the same time, or something that was co-occurring. 17.5% of those with a mental health condition were found to experience a co-occurring substance use disorder. So we share this because there are some folks who have lived experiences of both mental health and addiction, or both mental health and substance use challenges, and we honor and respect that as well. And our next slide, please. Common ground. We avoid diagnostic labeling and support individuals' self-determination. As people working within the peer support workforce, our role is not to diagnose someone. In fact, at our organization, Mental Health and Addiction Association of Oregon, we don't ask for someone's diagnosis. There's some initial paperwork that folks fill out when they would like to get connected to peer support services. And we intentionally don't ask for that information because we believe that we can connect with and support folks and really meet them where they are at without approaching things from more of a medical model. We're operating from a place that is really recovery oriented, and we support individuals' self-determination. And our next slide, please.
Here's another example of common ground. It's in the spirit of lived experience and honoring that lived experience that people with co-occurring disorders or issues or challenges should work with other people with those similar co-occurring disorders or challenges. So in peer support, it's not enough to say that, oh, I have a friend with a cousin who's got an aunt that, experienced bipolar one time in their life, and I am able to support you. That's not a peer. Similarly, they could be potentially, if someone does have a family member, they can support another family member going through something similar. But it is that shared lived experience. While not exactly the same, no two lives or experiences are exactly the same, but it is important to have that similar lived experience to be able to make that connection. So if someone who has only experienced mental health issues and recovery in their lives, to support someone who is working towards recovery from alcohol or other substances, there's a little bit of a disconnect in that they may have both been consumers of behavioral health services, but very different types of services and very different lived experiences. So it is important to have that at front of mind when connecting with the people you're serving, to have that similar lived experience. Next slide. Thank you.
And here we have summed up all those different common grounds. And I want to say this list doesn't list it all. I'm sure you can think of even more common grounds that you might have found in your experience, but here are some of the ones that we've talked about for the common ground between mental health and addiction peers. Lived experience. We all bring that lived experience, and that's really so key to being involved in peer support work. We need to have the lived experience. We all are person-centered. Unfortunately, both mental health and addiction peers see that society does not sufficiently fund addiction or mental health services. We fight against criminalization of mental health and addictions. We are a very diverse and inclusive workforce. We've both experienced trauma and challenges like electrocution, lobotomies, forced to take medications against our will or forced to receive services against our will in the name of science or in the name of what was considered to be a treatment. We all avoid diagnostic labeling and promote self-determination. We also recognize that all peers, all people with lived experiences, have a very diverse experience, right? So like Janie had just said, no one experience, no one life is exactly the same as another's. And we recognize that people may have, multiple intersectionalities within them. And finally, we believe that lived experience is really, really valuable. And that is so key to our profession. And we've got one final common ground to share on our next slide. And that is common ground. We believe that we can get better and have meaningful lives. That is something that is so key, having that hope for those we work with and believing that everyone can recover, and also respecting that that can look different for everyone is something that is really integral to doing peer support work, whether that is supporting folks around addictions or substances, or supporting folks with their mental health experiences. And with that, we have time for questions. We've got about 7 minutes left, and I see there's a couple questions in the chat box as well as some comments in the chat. So let me open up the Q&A box here. The first question I see from Mary is, what is considered specialty treatment? So when we say specialty treatment, we mean treatment that is delivered by someone who is specifically trained to do that. For example, if I am receiving services for my mental health from my primary care physician, that would not be a specialty treatment. But if I went to someone who was a licensed psychologist, then that would be a specialty treatment for my mental health. We also see like outpatient, inpatient, mental health or behavioral health or addiction services. Those would all be specialty treatments. And the second question I'm not sure about, it says identify as what. So Mary, if you could please share a little bit more information about that in either the Q&A box or the chat, I will try to answer that. Okay, I'm sorry. Yeah, I'm not sure where that was. And then Mary asks, another Mary, How do I find my personal code for the evaluation survey? So for the evaluation survey, there is a suggestion that is a code that I believe involves the first two letters of your mother's maiden name and a letter of your social security number or something, but that is included on the evaluation link that will prompt you. So if you remember those items, then putting them together, you'll be able to discover your personal code. Sometimes folks choose to create their own special code, and then that would just be something that folks would need to independently remember, because we aren't aware of what the codes are, unfortunately. It also keeps it confidential that way. All right. Are there any other questions that anyone has for us? We do have a couple minutes left. So we have time for one more question, and then I want to share a little bit of information about the eval to make sure folks have time to do that. All right, if we could go to the next slide, please. So here we have the contact information for both Janie and myself. If you have questions or would like to talk more following this webinar, please feel free to reach out to us at MHAAO.